Myeloma is a cancer of the bone marrow, just like leukemia. But in contrast to leukemia, which is a rapidly growing cancer of the bone marrow and needs to be treated immediately, myeloma is much more slowly growing. It's a cancer of the plasma cells. And the plasma cells are part of our immune system. And why is that important? It's important because when you try to treat the plasma cells, you try to treat cells that are part of our immune system. And there is no treatment at this point available that is so selective that it can only kill malignant cells. It will kill not only the plasma cells, but also our other part of our immune system. And all the patients with myeloma have an increased risk of infection because we not only kill the myeloma cells, but also the normal immune system. And they will have to be on prophylactic antibiotics to decrease their risk of certain types of infections. There are about 20,000 new patients with myeloma each year, and about 11,000 people die of myeloma each year. It's about 1% of all the cancers, but 10% of all the hematologic cancers, the blood-forming organs. The cause of myeloma is unknown, but we know that the risk increases with age. It's very uncommon to see younger people with myeloma. The older people get, the more likely, the more the risk is of developing myeloma. And as you can see, the large majority of the patients are over the age of 55. Myeloma is more common in men than in women. For every woman, there are 2 men who get myeloma. It's also much more common in African Americans compared to Caucasians. And the lowest incidence is in Asian people. And here you can see, this is age, the different age groups, and the frequency. You can see that it's extremely uncommon in younger patients. It's much more common in older patients. The median age at diagnosis is about 68 years. People always ask me, is myeloma getting more frequent? And we see more myeloma, but especially in patients over the age of 75. 10 or 15 or 20 years ago, patients over the age of 75 who developed myeloma and got sick, they didn't seek treatment. People thought, well, they're at a good age, why should we bother to treat those? Patients now that are in their 70s, mid-70s to 80s, most of them are still in excellent shape, and they still want to have treatment, and effective treatment, and live as long as possible. And here you see the hallmarks of myeloma. The bone marrow is infiltrated by those malignant plasma cells. And those malignant plasma cells, they have the tendency to cluster together, either in small clusters or in very large clusters. And when you have those large clusters of myeloma cells all together, they destroy the bone locally. And that's how you see those lytic lesions here, like you can see here in the skull of this patient. And the myeloma cells, they produce an abnormal protein, which you can detect on a protein electrophoresis, as you can see here, as a very narrow band. This band is not supposed to be here. No, in healthy people, it's supposed to go like this. And this narrow band is not supposed to be there. This is the albumin band, and everybody has that. And that shouldn't scare you at all. It's here that the action is. How do we diagnose myeloma? We take blood, we take urine, we see how much abnormal protein is present in the blood and the urine. We do a bone marrow biopsy and aspiration, and we do imaging tests. Not everybody with an abnormal protein has myeloma, as you can see here. These are all the patients who have an abnormal protein in the blood, an abnormal monoclonal protein, and the large majority of those patients have what we call monoclonal gammopathy of undetermined significance, which is a precancerous lesion. Those patients have a higher risk of developing myeloma, but some of those can be very stable for a long period of time. And as you can see, almost 2/3 have that condition. And only 15% of people with an abnormal protein have actually myeloma. And you can see when you have MGUS, monoclonal gammopathy of undetermined significance, that the risk of developing myeloma is about 1% per year. So after 20 years, you have about 20% of the patients who will need treatment. But 80% after 20 years will still not have any evidence of myeloma and doesn't need treatment. You can see that the risk of developing myeloma in patients who have this monoclonal gammopathy increases with the height of the abnormal protein. If the abnormal protein is very low, like you see here, the risk of developing myeloma at 20 years is low, about 14%. If you have an abnormal protein of more than 3 grams per deciliter, your risk at 20 years is about 2 in 3, about 65%. This is in contrast to smoldering myeloma, which is also a condition that quite a bit of our patients have. And smoldering myeloma is an in-between stage between MGUS and overt full-blown myeloma. Patients with smoldering myeloma typically have a higher abnormal protein and have more infiltration in the bone marrow with myeloma cells. And while the chance of developing myeloma in MGUS patients is about 5% at 5 years, 1% per year, patients with smoldering myeloma have about 50% chance of developing myeloma at 5 years. So it's clearly much higher than we see in patients with MGUS. And you can also differentiate different growths in smoldering myeloma based on 3 factors. How much is the bone marrow plasmacytosis, if there is more than 10% bone marrow plasma cells? How high is the abnormal protein? Is it more or less than 3 grams per deciliter? And what is the abnormal free light chain ratio? And if you have 3 of those factors that are all working against you, the chances at 5 years that you will develop myeloma are about 75%. If you have only 1 of those factors present, your chances of developing myeloma are only 25%. So for patients with myeloma, typically they used to present to us with bone pains. About 70% of the patients used to have bone pains. These days we see quite a bit of patients refer to us who accidentally were diagnosed with myeloma because they had blood work done. And the blood work showed a total protein that was too high, and the doctor did additional tests and found out that they have an abnormal protein, and were referring those patients to us. So we see patients in general a little earlier than we used to see 10 or 15 years ago. But bone pain is still the most common complaint of patients coming to us. Additional problems are weakness, fatigue, and weight loss. Anemia, kidney disease, or infections. Some patients have so much disease that they release calcium from the bone marrow into the blood, and they become what we call hypercalcemic. Some patients have abnormal proteins that are so high that it makes the blood thick and hyperviscous, and the blood doesn't get easily through the smaller arteries and veins and causes problems. And sometimes the myeloma starts in one of our vertebral or spinal bodies, but grows outside and compresses the cord and causes problems. Staging used to be done according to the Dury-Salmon criteria, but lately is done, and I think much more appropriately, by using only 2 factors, beta-2 microglobulin and albumin. And this is the international staging system. And if the beta-2 microglobulin, which is a measure of kidney function and also a measure of how much myeloma you have around, if that's low and the albumin is high, you have a favorable stage 1 disease. If your beta-2 microglobulin is high, either because you have lots of disease or because you have abnormal kidney function, your prognosis is less favorable. And this is a stage in between. But in spite of the fact that those are important classifications, and whenever we analyze our data, we always see that those stages apply and relate to outcome. There are more important prognostic factors, as we will come to now. Before we decide on treatment, the first thing we will do is look at what the myeloma stage is. Is this a patient that really needs treatment, or can we wait? And if we are not sure, we will typically wait and make sure that there is a need for treatment before we will start. We will look at the age of the patient. The older the patients are, the more likely it is that they will have some other morbidities like heart disease or lung disease or kidney disease that makes it a little more difficult to give aggressive treatments, basically looking at overall health status. Geriatric assessment, especially the mental status of patients, because those treatments like we provide are intensive and require the patient to cooperate very intensively with us. And then especially cytogenetics, which is one of the most important prognostic factors, if not the most prognostic factor.